We've discussed the usage of the operative microscope briefly in GYN and GU, but it is very commonly used in ear surgery. Know that it is not typically draped out, but instead there may be sterile handles that are put on the microscope, similar to light handles for the OR lights. Another common piece of equipment is a power drill, which is used on the bony structures of the ear, like the mastoid bone. These drills use a very small burr to access the structures that are behind that bony tissue. Here's an ST consideration that applies to us every single time we use a burr of any kind. When the burr is in use, it gets hot. It is the scrub tech's job to have irrigation solution at the ready to irrigate the tip to keep the tip cool while it is in use. Furthermore, the scrub should have suction ready to suction the irrigation they use to keep the burr cool. Pay attention to the visual field for the surgeon and do not allow the irrigation or the suction to impede their vision during the procedure. Our last couple slides address sponges and medications used in ear surgery and dressings for the end of our procedures. Depending on the procedure, it may be indicated that the sponges on the field be very small, like a cottonoid, or they could be large as a lap. Procedures that involve any infection or working through the mastoid bone are considered larger procedures, while BMTT procedures are quick and less invasive. Regardless, all sponges are counted at the beginning, during closure, if that exists, and at the end of the procedure. Most ear procedures require patients to be under general anesthesia, although some procedures are performed so quickly that the patient is given their anesthesia by mask and not intubated at all. Other procedures are more lengthy and require traditional general anesthesia with intubation. The various medications used in ear surgery often include gel foam and bone wax for hemostasis, antibiotic and anti-inflammatory drops, in addition to irrigation solution, which we've already discussed. You will see epi added to medications in ENT. And do you remember what the purpose of adding epi to our medications is? As for dressings, sometimes none are used at all. Occasionally, they leave behind a cotton ball to be removed in PACU. But in procedures that involve a bit more work, patients usually get either a Glasscock or a mastoid dressing. The Glasscock dressing is the more conservative dressing of the two and is used for patients that undergo minor ear procedures like a stapedectomy or tympanoplasty. The Glasscock features a plastic component that has Velcro straps that wrap around the head while holding 4x4 sponges in place. A mastoid dressing, on the other hand, is more complex and it involves fluffed gauze sponges secured by a Kerlix that is wrapped around the head and chin. Plastic procedures, which we will cover next semester, involving the ears employ the same positioning, prepping, draping, medications, and dressing considerations. Now we're going to transition into information over the anatomy of our snifferoo and the information about our throats. First off, our noses and structures located in our throats serve many purposes related to respiration and vocalization. Occasionally, structures of the digestive system are also involved. I have assigned a TED Ed video regarding the nasal cavity. It's not nearly as amazing as the ear video, sorry about that, but it is still a good resource because it takes you into the nose almost like the Magic School Bus. Make sure you print the outline I made for you on this TED Ed as well and have it with you when you watch the video. You might have already watched it. If you didn't have the outline with you when you watched it, go watch it again with the outline because I put time markers on there and everything for you. This information may be repetitive for you, so I'll be brief. The external nose that we see is formed by two U-shaped cartilage structures. This cartilage makes up the lower two-thirds of the nose, while the upper third is composed by the nasal bone. This slide shows you the nasal bones and cartilage, which is also found in your book on page 696. The nares are the natural orifices at the bottom of the nose. The internal components of the nose are lined with a mucous membrane, and nasal hairs help filter the air off foreign particles. The septum divides the nose sagittally into a right and left half. Inside your nose, you have paired sinuses on both the right and left sides. The sinuses are highly vascular and lined with mucosa that warms, humidifies, and filters the air we breathe before it gets to the lungs. There are 4 sets of sinuses. They are the maxillary, the frontal, the ethmoid, and the sphenoid sinuses. The largest of these sinuses are the maxillary, which are found behind our cheeks. You will want to know where each pair of sinuses reside. When the sinuses chronically fail to function properly, the patient's quality of life is severely affected. Think about a time when you have had a head cold, or even a sinus infection, and how miserable you were. That is their life for months or even years on end. Antibiotics don't help. Sleeping meds don't help. They often suffer from headaches surrounding their sinuses, and that's just how they live until they discover sinus surgery, and their life is forever changed. Isn't that cool? You get to be a part of that. You can't tell me you've never had a stuffy nose, and that moment when the cavity clears and you breathe unobstructed for the first time in days, that it doesn't make you delirious with joy. It happens to me at least once a year. I can't even begin to imagine the relief a patient feels when they get to do it for the first time after a successful sinus surgery. Oof. Moving on to the pharynx now, you should already know that it is further divided into 3 structures: the nasopharynx, the oropharynx, and the hypopharynx. Important structures to be able to identify in these regions are the palatine tonsils, adenoids, uvula, and epiglottis. Sometimes people lump the hypopharynx in with the larynx, but I would prefer for you not to do that while you're learning these anatomical structures right now, because the larynx is even further divided into 3 more sections. The anatomy of the larynx is particularly important to anesthesia providers, but it's also crucial for us to know our anatomy for procedures of the neck, so as not to interfere with anesthesia's components or injure the extremely delicate structures located there. Within the larynx there are the supraglottis, the epiglottis, and the glottis, all of which deal in and with the vocal cords. Remember, adjacent to the larynx is the esophagus and the hypopharynx. What organ does the esophagus connect with distally? So, if there are 2 cylindrical, longitudinal structures running parallel to one another, can you empathize with anesthesia for a moment when they're trying to intubate someone and their ET tube keeps going into the esophagus instead of the trachea? What do you think is going through the operative team's mind if there's uncontrolled bleeding in this region? Otorhinolaryngologists will occasionally need to perform diagnostic tests in the operating room in order to see a specific anatomical structure directly. You may be involved in these diagnostic tests, but remember, unless the case is operative, I need you to log it in the second scrub roll of your specialties, okay? I'll help you keep track of this. There are rules. I'll help you out, don't worry. It's also customary for patients to receive MRIs, CTs, and ultrasounds to rule out diseases or structural abnormalities. Be prepared for a surgeon to request the results of those diagnostic tests to be readily available in the OR for their operative procedures, and each facility may achieve this task differently, so be on the lookout for how your facility does it.